Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me for this talk on procrastination. Pathological procrastination, to be specific. From the Latin pro, on behalf of or in favor of, and cras, tomorrow. In favor of the morrow. Today, I'm going to talk to you about procrastination, the regular kind and the pathological kind, and the quick fix for both under the medical model. The pharmacological solution that works in the short term and immediately in virtually all instances, all but guaranteed, if a patient can tolerate it. Pathological procrastination is not garden variety procrastination. I'm talking about pathological procrastination, which is not a formal DSM-5 diagnosis, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's not a formal diagnosis, but it certainly exists, and it can certainly be identified and diagnosed as a symptom, if not a formal condition. We are decidedly at a disadvantage, though, without diagnostic criteria. So just to make sure everyone knows what I'm referring to when I say pathological, is that it's different from normal procrastination that we all do because it's so persistent and severe that it has become clinically relevant. That is, it requires the attention of a clinician and treatment of some kind. Not always pharmacotherapy, not always treatment with medication, but some kind of treatment. That makes it clinically relevant, and that, in my book, makes it pathological. But that's still a fairly broad definition, which I'm going to further refine by describing one variety that's associated with an anxiety spectrum condition, usually OCD, Obsessive-Compulsive Disorder, that's accompanied by a feeling of being overwhelmed and paralyzed, and another that falls under the ADD-ADHD umbrella, attention deficit disorder, that doesn't feel anywhere near as dire if there's any anxiety at all. And contrasting those with ordinary everyday procrastination. We all do it, but it doesn't warrant a diagnosis unless it's so persistent as to be disruptive, causing real-world problems and/or significant subjective distress. That's true of all psychiatric conditions. You can have blatant symptoms, OCD rituals, for example. But if there's no problem, no academic or occupational problems, and it's not bothering anybody, no social problems, and not even subjective distress, there can be no diagnosis. Individuals who have pathological procrastination have a unique brand of this behavior that, in the case of OCD-related procrastination, causes a great deal more suffering, subjective distress, as the DSM-5 calls it. I myself have OCD, as many of you know, and I've experienced this level of procrastination, so I know what it feels like. And by the way, because pathological procrastination is not an official diagnosis, there's not much out there on the subject. What research I could find on so-called chronic procrastination simply showed a strong association with anxiety and depression, which is not surprising. Also, low self-esteem. But there's a chicken and egg question there. We don't know whether the anxiety and depression are causing the procrastination or vice versa. When I talk about the OCD-related procrastination in a moment, that is, in my opinion, definitely caused by the anxiety disorder that's there. It's not anxiety because you're procrastinating, it's dread that is leading to the procrastination, the irrational emotion that leads to the behavior that maybe then loops back and gives you more anxiety, but the anxiety comes first. And that's true of endogenous anxiety syndromes. I've done recent videos on this, that when it's endogenous anxiety, anxiety that comes from within, that comes from your genes, that comes first. It comes before the stressor or whatever the problem behavior is. It's a priori. The research on chronic procrastination also found an association with other mental health disorders, especially OCD and ADHD. OCD and ADHD are two completely different kinds of disorders. And in my opinion, at least, the procrastination that we see in one is not the same beast as what we see in the other. We may call them both problematic or pathological procrastination, but those are not the same. I'm convinced of that. That's according to me. I'm convinced of that because I've experienced one. I don't have ADD, ADHD, so I haven't experienced the other problem, but maybe this will be more clear in a minute. Whatever else, there are not a lot of scholarly articles out there. And for that reason, a lot of what I'm going to say today is a reflection of my own personal experience, as well as discussions that I've had with patients. So anecdotal information to be sure, but I know for a fact that others have experienced this symptom because I've had those conversations with many patients, and I have the best vantage from which to describe it because I've lived it. This is in the context of OCD. So this is actually the next installment in my Esoteric OCD Symptoms playlist, number 7, I think. The crippling, paralyzing anxiety felt by individuals with pathological procrastination in the OCD camp in the context of Obsessive-Compulsive Disorder. There are 2 DSM-5 diagnostic prongs. Whatever condition we're talking about, whatever the criteria, the condition must cause significant difficulty in social, academic, occupational, or other important areas of functioning, quote unquote, and or significant subjective distress. You have to have one or the other or both of those 2 to make a diagnosis. Because regardless of what the behaviors and thoughts are, if it doesn't bother anybody and it's not causing any problems, it's not maladaptive or dysfunctional in some way, then we can't say that it's an illness. And it's the latter criterion, subjective distress, that's what really sets OCD procrastination apart from the others. What is it? What makes it so special? I would say the feeling of being overwhelmed. And not just overwhelmed, but paralyzed. It's dreading a task. It's irrational, all right? It's not logical because it is due to anxiety, and anxiety is by definition an irrational emotion. But when you even think about doing it, you're just filled with this sense of urgency about the fact that I gotta get it done, oh, the deadline's approaching, I gotta get that done. And yet it's coupled with an even stronger, it just grips you in your guts, this you don't want to even turn your attention to it. And it is irrational, but it's like you're afraid of what it's going to feel like to get started. It's crippling. And it usually is an unpleasant task, but the feeling is way, way in excess from how unpleasant the task really is. The other esoteric principle is its connection to perfectionism. Pathological perfectionism is seen in OCD, where the person can't ever finish a task because of a compulsive drive to make the work product perfect. And of course, that's a nearly unattainable goal most of the time, and so time runs out on these individuals. They're inefficient. Please see my video on OCD personality for a more detailed discussion about that. But that's when someone is actually working on something. Similarly, though, there's an all-or-nothing dogma, very similar to perfectionism, that prevents a person with OCD from even starting a task. Paying one's taxes, for example. If the person believes it can't be finished in one sitting, and it is usually either an unpleasant task or a tedious one that gets put off, just like we all do. But then there's also the feeling/belief that we have to do it or not do it, but just getting started on it, doing a little at a time, is not an option. When in fact, it is. Logically, it is. And that's actually one of the cognitive behavioral strategies we use to get around this roadblock. One non-pharmacological solution. Sure, it's an option. Of course, getting started is an option. It doesn't have to be completed all at once. It doesn't have to be all or nothing. The execution of the task doesn't have to be perfect in that way. I know that strains logic, but keep in mind, this is not necessarily a conscious thought that most OCD sufferers are having, but it's what I've been able to figure out about my own reluctance to chip away at an unpleasant task. I feel like when I do it, I'll crank it out in one sitting, get it over with, so to speak. But until then, until I think I can sit down and do it all, I don't want to deal with it. Even if it's sitting there in my inbox, torturing me every day. I am, in fact, dealing with it by not dealing with it. And that's the irony. There's so many ironies when you really look at the behaviors and the beliefs that arise from irrational anxiety. The irony is that once begun, a person gets on a roll, usually, and often does finish in short order. And the task that seemed Herculean is behind them. The problem was getting started, not actually doing it. The best strategy really is to chip away at it, because even if a person can't make short work of it, doing a little bit each day makes a molehill out of a mountain. It's so much easier that way. But all of those are logical arguments, and OCD anxiety is irrational. It doesn't care about logic. I always say, you feel what you feel. You don't choose your emotions. They just happen. And anxiety, by definition, is irrational. OCD is all about doing things the hard way, opting for what seems like the lesser of two evils when one of the evils is completely imaginary. I have videos on all of this. Please check out those playlists. But one capitulates to dread, however excessive or misguided the feeling. So knowing this strategy of just do a little at a time may not help the person who feels paralyzed every time they turn their attention to it, every time they look at their inbox. But it is the main behavioral intervention, and it's often best to pair it with medication when necessary. One very specific plan that I give patients is to devote 1 hour each day to the terrible task. And make it as specific as possible. I don't just tell them, well, just get started on it. Just do a little bit every day. No, I make it very specific. I give them an assignment, and those with OCD really like this. I tell them, pick a time that's convenient, a time where you can devote an hour, 60 minutes, let's say 9 a.m. From 9 a.m. to 10 a.m., you're going to do this task. You're going to sit down, you're going to gather the materials, and even if you sit there and stare at them, stare at the pages for 60 minutes and don't do anything, that's what you've done. You make that deal with yourself, that you can get them and go. Of course, no one ever just sits and stares at the paper. They get bored, they start shuffling papers. You don't actually sit there and do nothing. But what that does, though, is you're not giving yourself any goal of how much you're going to do. Because even if you can get past all or nothing and you can accept, okay, I'll just do some of it. Well, how much are you going to do? You want to do a significant portion, or it's not worth starting. And so you get sucked back into that fallacy of you have to get a certain amount done. You remove that piece. So now we don't care how much you get done. You're just going to spend 60 minutes on it. And you get as much done as you get done. And so you remove that piece that's really the stumbling block, whether a person is consciously aware of it or not. And they spend 60 minutes. They get more done than they anticipated they would in those 60 minutes. They may just decide to just keep going, but even if the task truly can't be done in one sitting, then you've chipped away at it. And tomorrow at 9 a.m. you have an appointment with your desk and you pick up where you left off. And because you're being very regimented about it, you attack it that way and it gets done. And the task really isn't that bad. Once you start doing it, you see that it's not that bad. It was really some nebulous, irrational fear you had about delving into it, turning your attention to it. I'm doing it right now with a lawsuit against my former landlord that's getting pretty dusty. The statute of limitations is probably going to expire on it before I actually move on it, and it's because it's unpleasant. I don't want to think about that conflict. I don't want to think about my former landlord and the lawyer that I hired that wasted a year and blah, 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 blah. All this negativity. I don't want to do it. It's not worth it to me right now. And maybe it never will be. I may abandon it eventually. But for now, I keep torturing myself about it because I'm not ready to let it go. And yet, I just don't want to do it. I just don't want to do it. It's just that feeling. All I can say is I just don't want to do it. It's negativity. So cognitive behavioral restructuring can help, especially if the person doesn't have OCD and is a little bit more rational. But for most individuals with OCD, medication is indicated, and you compare the two because they know it can be done and that it doesn't need to be finished in one setting and whatever else. Logically, they know that. But you can't argue with an emotion, abject dread, when it comes down to it, that they can escape just simply by saying, not today, tomorrow. But you still felt the dread. And this is the irony, because you end up suffering more. Because the overwhelm that makes a person cringe and suffer for a few seconds, feeling torn between this impending deadline, the need to get it done, and the dread of starting the task, it feels terrible. The irony is that suffering, which is usually daily, is so much worse than the unpleasantness of just getting started. Whether it's your taxes and you don't really want to turn your attention to it because you haven't been paying your estimated tax payments and you just know you're going to be in the hole for a lot of money. Whatever it is that's triggering the anxiety, you don't want to turn your attention to it because it's dreadful. But the agony of feeling that dread and anticipation, it's the anticipation of feeling that if you turn your attention to it because you imagine turning your attention to it. So you feel that. Plus you feel the stress of, I'm not getting it done, I need to get it done. If I don't file my taxes, I'll get in even more trouble, right? And you add those two together every single day. When you add up all of those moments of telling yourself, I need to get it done, and cringing and squirming and worrying about the fact that you're not doing it, that you can't even start doing it because of that anxiety that says, not today. All of it adds up to so much more suffering than whatever unpleasantness is inherent to the task. You suffer so much more than you would have had you simply done it. And when there's no actual deadline, this internal struggle can continue a little bit every day for years until someone either gives up or it gets done. And as I'm standing here, a board-certified psychiatrist, telling you these truths and laying it out for you, that this is what I've figured out about it and this is what's true, is it going to help me tomorrow when I look at my inbox and I see that paperwork, the legal forms and the evidence that I've accumulated, knowing that I'm actually putting myself through more by postponing it? Probably not, because I know this truth. But in the moment when you're feeling it, it's so easy to just say, okay, tomorrow. And you throw it and you turn your attention away from it. And then all of that, the unease and the stress from both angles goes away until tomorrow. So it's so irrational, the feeling, because emotions, you can't argue with an emotion. Emotions always win. In that tug of war for behavior, when it's rational, logical thoughts and your wiser self and your gut feeling, especially if we're talking about fear and a lot of times anger and lust, any strong, overpowering emotion, you will do the thing that is stupid, the thing that is not in your best interest, because that's what your emotion was telling you to do, and your emotion was calling the shots. Emotions almost always win. And the more unpleasant it is, the more enslaved we are to it. So anxiety needs to be treated. And there's no quick fix there. There's no cookie cutter recipe I can give you for successfully treating anxiety. Anxiety can be tough. The procrastination piece, though, can still be solved with the quick fix that I'm going to talk to you about today, because procrastination that's persistent and excessive and that causes negative outcomes and significant anxiety can otherwise also be seen in ADD, ADHD, attention deficit disorder, a condition that is not anxiety spectrum. This is less esoteric. These individuals don't feel overwhelmed and paralyzed, but they have trouble prioritizing and organizing and staying on task. And so they grapple in a different way. There may or may not be any internal struggle to speak of in patients with ADD, but they end up procrastinating because of an inefficiency of a different brand. The quick fix that I want to share with you today involves taking not anxiety medication, but ADD medication. Now, obviously, again, just to reiterate, if a person is suffering from OCD or some other anxiety disorder or some other mental disorder, they need treatment for that. And if that includes pharmacological treatment for OCD, that's usually the case, then that medication needs to be administered according to the standard of care and taken into consideration when you're thinking about using ADD medication. But ADD medication fixes all procrastination immediately, whether it's pathological or common variety, and whether it occurs in the context of OCD or ADD or none of the above. Stimulant medication, okay, so not all ADD medication, not Strattera, not Capve, stimulants. Stimulants reduce procrastination in 99% of cases, and I just made up that statistic. This is according to my clinical experience, in which actually 100% of cases responded. But I guess I have to acknowledge the possibility that it might not work for some individual out there. I think, though, that if this treatment option failed, it would be because the anxious person couldn't tolerate a stimulant, not because the medicine wasn't effective. I really believe that if a person could continue taking it, they would surely, almost certainly, find themselves getting over that hump and finding the courage they need to begin to tackle that task, because stimulants give you that confidence and that energy. But more than that, in patients who aren't necessarily dreading, who don't need boldness, they don't need courage, they too respond, because stimulants also directly motivate. Specifically, okay, I'm being very specific here, they provide initiative. And I really want to make sure that I'm being clear here. It's not just that they wake you up and they give you more energy and they boost your mood, right? So you're feeling better. Part of that is feeling like you want to do things and you want to get things done. That is very specific, and it is not the same thing as the euphoria that you feel, and it's not the same thing as the expansiveness that you feel. You feel gregarious, you want to interface with people and talk, and those are other effects. All of that is separate from initiative, from the desire to get things done. And again, the ability to concentrate for long stretches, the increased cognitive capacity, all the other things that stimulants are doing for you. They make you smarter. They get you going, they get you moving, but they also motivate you in a task-oriented fashion. One of the symptoms of mania, which is associated with being overstimulated by either drugs or medication or bipolar disorder, but ultimately actually by catecholamines, catecholamine neurotransmitters, right? That's the final common pathway. Dopamine and norepinephrine. Part of that state of having too much energy is excessive motivation, an increase in goal-directed activity, quote unquote. I'm quoting the Diagnostic and Statistical Manual of Mental Disorders. It is a finding, it is a symptom. Not only are they talking fast and moving around fast, but they want to do things. They want to go places, they want to do things, they want to interface with people, they're super ambitious. People who are manic for whatever reason feel a drive to get things done, to get things accomplished. They're super in the mood to do that. And that's exactly what you need when you're paralyzed by procrastination, or even if you don't feel particularly paralyzed, let's say you're just too distracted and you can't concentrate long enough to effectively plan or organize, and that's why you keep putting it off. Or let's say you're just lazy. It works. increasing the catecholamine neurotransmitters dopamine and norepinephrine works just as well in OCD as ADD as for lazy people. You have to be careful not to induce a panic attack in patients with anxiety spectrum disorders, and there are contraindications. I mean, you wouldn't give it to somebody with poorly controlled epilepsy or acute psychosis. I mean, there's a long list of contraindications. If you want that list, you can watch my Vyvanse video. And stimulants exacerbate OCD symptoms even if they don't induce panic. But in my adults who don't have ADD, in my estimation, but who complain of distraction and also procrastination, I can guarantee to them that taking an appropriate dose of Adderall or Vyvanse or Ritalin or even Provigil or Nuvigil, and in some cases even the antidepressant bupropion, Wellbutrin, the least stimulating of the activating medications, all of them will help dissolve procrastination by increasing dopamine and norepinephrine. Whatever is making a person procrastinate. Also, there's a tenacity that stimulant and stimulating medications confer. The medications help you not only commence a task, but also to see it through. I said before that once you get started, a lot of the time you tend to get on a roll and knock things out because it's much easier to continue doing a task, even one you've been avoiding, than to begin doing it, especially if you have an irrational dread of it. And then once begun, you say to yourself, hey, this isn't so bad. Who hasn't experienced that? But on these medications, one definitely exhibits a whole other level of tenacity, whether it's expected or wanted or not. It's probably an aspect of the medication's ability to increase concentration, because too much and you hyperfocus, to the neglect of other priorities like eating and sleeping even, because you're so focused. Even if you're not being particularly productive, that's called hyperfocusing, or going down the rabbit hole, as I like to say. That happens a lot with the internet. A person takes their Adderall and they start doing research on the internet, and 2 hours, 3 hours go by, and they haven't gotten the information that they originally sought, because they just kept going deeper and deeper into sometimes tangential information, and sometimes they just get stuck. And you see them sitting at their computers and they're not moving and they're not blinking, and a lot of times family members fuss at them because, come on, we gotta go, you said you were gonna come have dinner, come eat. And a person will be hyper-focused. So initiative and tenacity, those are two different things. And they are a 1-2 knockout punch to procrastination. I've taken all of the aforementioned medications except Vyvanse, and I can vouch that all of them, including Wellbutrin, for me, have motivated me to push beyond procrastination. It's like the procrastination suddenly just melts away on its own. You're not really pushing through anything. You might not even be thinking about it. You take the medication and you suddenly find yourself, you're in the mood to do it. You find yourself doing it, even if you're not consciously thinking, oh, I should get that done. And you look back and you think, oh yeah, where was my procrastination? I guess I sidestepped it. No, it wasn't there. It went away. Suddenly, you're super motivated. The antidepressant Wellbutrin also works, especially, perhaps not surprisingly, in patients who are actually depressed and for whom that is the underlying reason that they're not getting their stuff done. So depression is also in the differential. A clinician certainly needs to perform a comprehensive psychiatric evaluation and not just blindly prescribe a stimulant, okay? I'm not advocating for that. I'm just telling you it will work. There are contraindications, and we need an accurate diagnostic paradigm under which to safely operate, obviously. But in the absence of any contraindications, unless an antidepressant or an anti-anxiety medication is also needed or would be better, a low dose of any medication that blocks the reuptake of dopamine and norepinephrine, plus or minus causing the additional release of dopamine, will get the job done. Literally. Because in the end, it's those neurotransmitters coming to the rescue, acting on the frontal lobe, probably. There it is, one quick pharmacologic solution when time is of the essence and there are no contraindications, because those neurotransmitters, in addition to everything else they do, act directly on the specific symptom of feeling like putting things off. because it is a feeling before it becomes thought and then a decision and a behavior or lack of behavior. Not doing something is also behavior. The feeling of, I can't do it now. Can't. And I'm obviously talking about the patient with OCD. For patients with the ADD, it is perhaps less a feeling and more to do with executive functioning, cognitive functioning. They're two different animals. They're two different beasts. That's not the same. Procrastination. We may call it pathological procrastination. And finally, even in individuals who are not procrastinating or complaining of that, who are taking a stimulant, say for another reason, say a patient taking Vyvanse, it's FDA approved for binge eating disorder. That patient will probably notice how much more they're getting accomplished in a day. Not just because they're out of bed and better organized and even more inspired, because there's a certain creativity that you get when your mood is elevated, right? Manic individuals are super creative individuals a lot of the time. No, not because of any of all of that, but because they're more motivated and because they're sticking to tasks. They have that tenacity. Because in addition to quieting their obsession with food in those patients, food noise is what one of my patients calls it, the medicine is increasing goal-directed activity, increasing it above baseline even if it wasn't low to begin with, whether we want it or not. All right, it's just automatic behavior that ends up happening. So if you are having trouble with procrastination, for whatever reason, you can talk to your psychiatrist about it. Even if your psychiatrist doesn't want to treat you long-term with stimulants, you can certainly discuss this video with your provider, because if they give you a medication, it doesn't have to be a stimulant, but if they give you a medication that increases dopamine and norepinephrine by blocking their reuptake, and especially if that medicine also causes the release of dopamine, in which case you are talking about a stimulant, and specifically amphetamines, and Vyvanse, which is a prodrug, but not methylphenidate. Those medicines also cause the release of dopamine. So definitely if you give one of those, but there are other options, and modafinil and armodafinil should not be forgotten about, but not Strattera and not clonidine. Thank you for listening. As always, comments and questions are welcome.